Good afternoon, everyone, and welcome to the sixth webinar of the 2021 in the ACCP Immunology and Transplantation PNR webinar series. My name is Lauren Schumacher, and it's my pleasure to moderate today. Today's webinar is a 2021 resident research webinar, and we are honored to have an excellent group of pharmacy residents present for us today. In a moment, I'll turn it over to our speakers to begin the presentation, but first, here are a few quick notes. If at any point during the presentation you have a question for the speaker, please submit your question by using the chat functionality on the left-hand side of your screen and send the question to the presenter group. We will take questions at the completion of the presentation. To claim CE credit for today's webinar, you must be an ACCP IMTR member and complete the evaluation at the conclusion of the webinar, including an active email address. Following the CE, you will receive an email to claim your CE, and you must complete it within 10 days. If you are viewing the webinar with multiple members under a single login, please email Ricky Evans to request the link. You are not required to attend all 4 CE webinars to receive credit for attending today. And if you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make sure the presenter is aware through this chat functionality. There's also a live chat on the upper right-hand corner of your screen where you can get live technical support from any meeting. Without further ado, I will turn it over to Bethany Lane. Bethany Lane is currently completing a PGY2 and solid organ transplant at Ochsner Medical Center in New Orleans. She's completed her PGY1 training at the Cleveland Clinic Medical Campus in Cleveland, Ohio, and pharmacy school at St. John Fisher College in Rochester, New York. She has accepted a position at Cohen Children's Hospital in Long Island, New York, as her pediatric transplant specialist, and is excited to continue her journey in transplant pharmacy and look forward to the opportunity to help children and families understand their medication regimens and the importance of these medications. Today, she'll be presenting on quantifying the interaction between posaconazole and tacrolimus in liver transplant recipients, a practical approach.
Thank you for that introduction. If at any time you can't hear me, please let me know. As Lauren mentioned, today I'll be presenting on my research project titled Quantifying the Interaction Between Posaconazole and Tacrolimus in Liver Transplant Recipients. Following transplantation, prophylaxis for certain infections is common, including against potential fungal infections, as the cumulative one-year incidence is about 3.1%. Commonly, these are due to Candida species, and often prophylaxis will utilize agents such as fluconazole in high-risk recipients. However, if mold coverage is warranted, alternative agents such as posaconazole, isavuconazole, or voriconazole can be used. At Ochsner, our prophylaxis commonly or historically included the use of nystatin until prednisone doses were less than 15 milligrams per day, or if the surgeon considered patients to be of high risk, we would utilize fluconazole therapy. However, recent construction at our institution prompted the expansion of our prophylaxis to include mold coverage, and thus patients were either put on posaconazole, 300 milligrams, daily for 4 weeks, or isavuconazole for 4 weeks. Though we utilize the azole antifungals, their mechanism of action may lead to many potential complications, especially with interactions of their immunosuppressive regimens. And this is due to the inhibition of 14-alpha methylase that's commonly seen with our azole antifungals. Though they selectively target fungal cell membranes, we can also see non-selective inhibition of human CYP enzymes. And of particular concern is with CYP3A4, as that's needed for our tacrolimus metabolism. Historically, there has been little literature defining the interaction, especially in our abdominal transplant population, and the use of previous formulations of posaconazole. The first trial by Sansone, Parsons, and colleagues evaluated cyclosporin in heart transplant recipients in combination with posaconazole, as well as in tacrolimus in healthy individuals in combination with posaconazole, with the aim to analyze the pharmacokinetic effects when co-administered. In the heart transplant recipients, this was a multi-dose, single-center, open-label study, and Sansone, Parsons, and colleagues did note that there was an increase to cyclosporin exposure when administered with posaconazole. Ultimately, patients in this study did require anywhere between a 14 to 29% dose reduction. Conversely, a single-dose tacrolimus given in healthy individuals, followed by posaconazole therapy for 8 days, found that there was increased systemic exposure to that single dose, with an increase in Cmax and AUC by 121% and 358% respectively. From this trial, Sansone, Parsons, and colleagues concluded that a dose reduction in calcineurin inhibitor therapy should be utilized when using concomitant therapy, though we can see between cyclosporin and tacrolimus that various dose reductions are required. Another trial by Van Hove and colleagues sought to identify genetic and clinical predictors of the magnitude of that interaction between tacrolimus and either voriconazole or posaconazole in renal and lung transplant recipients. These patients received concomitant therapy, and of note, no kidney transplant recipients were in that posaconazole group. All of those patients did receive voriconazole. Ultimately, Van Hove and colleagues did note that tacrolimus doses had to be reduced by a factor of 5 milligrams during voriconazole therapy and 3.7 during posaconazole therapy, with changes in dose-corrected trough concentrations of 4.4 for posaconazole therapy. Van Hove and colleagues did conclude that a 66% dose reduction, as recommended by the package insert, may be insufficient to manage these patients. Due to the limited literature available evaluating this interaction with tacrolimus and posaconazole specifically, and the current literature being limited by small sample sizes, limited patient populations, primarily using cardiothoracic transplant recipients, and the use of inconsistent posaconazole formulations, our study aimed to quantify the interaction between tacrolimus and delayed-release posaconazole tablets. The primary endpoint was the difference in day 5 tacrolimus concentration to dose ratio with posaconazole compared to control, with secondary endpoints including the incidence of AKI and biopsy-proven acute rejection within 1 month of azole discontinuation, as well as the incident hospital length of stay and the rates of supra or subtherapeutic tacrolimus troughs. This was a single-center, non-interventional, retrospective study including patients between August 1st, 2017 and September 30th, 2020. Patients were included if 18 years or older and received a liver transplant and were maintained on tacrolimus-based immunosuppression, as well as received at least 1 dose of either nystatin or posaconazole. Patients who received a combined multi-organ transplant or who were maintained on non-tacrolimus-based immunosuppression were excluded from the study. Baseline demographics did utilize descriptive statistics, and categorical variables utilized chi-squared and students' t-test for continuous variables. Ultimately, 543 liver transplant recipients were screened for inclusion, with 217 patients ultimately being included, 41 in our posaconazole group, and 176 in nystatin. The most common reason for exclusion was the use of other antifungal agents, whether this was no antifungal use or use of an alternative azole. There were no significant differences between baseline characteristics between our posaconazole and control group. On average, the age at baseline was approximately 55 years, and we had a predominantly male and Caucasian population. Evaluating the primary endpoint, the day 5 concentration to dose ratio did increase significantly in those receiving posaconazole compared to control, with about a 3-fold increase in concentration to dose ratio seen at day 5 of therapy. Evaluating this interaction at day 2, there was about a doubling of the concentration to dose ratio compared to control, suggesting that this interaction can impact therapy as soon as day 2. Overall, these findings do largely confirm to maintain a similar tacrolimus trough concentration with the use of posaconazole therapy, that a 2/3 dose reduction, as recommended by the package insert, is warranted. In terms of secondary endpoints, there was no difference in the incidence of AKI during concomitant therapy or BPAR within 1 month of discontinuation of antifungal therapy. Additionally, there was a trend towards a longer length of stay with posaconazole, though this cannot be solely attributed to posaconazole therapy, as there are many potential confounders that could impact this. Additionally, those who received posaconazole were significantly more likely to have a therapeutic tacrolimus trough by day 2 and day 5 of therapy compared to control. Additionally, those receiving posaconazole were at a reduced risk of being discharged without having a therapeutic trough compared to those receiving control. Lastly, those receiving posaconazole therapy did ultimately require a significantly smaller weight-based dose compared to control, with this difference being clinically significant by day 5 of therapy, whereas those receiving posaconazole required approximately 3 milligrams for a 70-kilo patient compared to 6 milligrams for that same 70-kilo patient with in the control group. In those receiving concomitant therapy with posaconazole, there was a significantly higher risk of having a supratherapeutic trough compared to control, as well as having those receiving nystatin having a significantly higher risk of having subtherapeutic troughs. At discontinuation of posaconazole therapy, there was no difference in supratherapeutic trough concentrations. However, those receiving posaconazole were significantly more likely to experience a subtherapeutic trough concentration following discontinuation of posaconazole. These out-of-range tacrolimus concentrations can highlight where a pharmacist can be heavily involved in medication management for these patients, as if they're at increased risk of having out-of-range concentrations. Overall, from this study, we can conclude that concomitant therapy with posaconazole did result in a threefold increase in that tacrolimus concentration to dose ratio compared to control, and those receiving posaconazole were more likely to experience a supratherapeutic trough, though did not have a significant difference in the rates of AKI. Similarly, at discontinuation, we did see higher rates of subtherapeutic troughs, though there was no difference in the incidence of BPAR. Strengths and limitations to highlight from this study. One of our strengths is that we did utilize posaconazole delayed release, as prior studies have mainly utilized either posaconazole oral suspension, and this can help or contribute to altered absorption compared with our delayed release tablets. Additionally, this did include liver transplant recipients, and so this adds to our literature in that abdominal transplant population, as prior literature has mainly utilized cardiothoracic patients. And this was reflective of clinical practice with dose adjustments and reflective of what we would do. Some limitations, though, is that we did have a small sample size with only about 40 patients in our posaconazole group, and additionally, we did not take into consideration the liver function or postoperative courses of these patients that could potentially affect the metabolism of tacrolimus. And lastly, this was a retrospective design and thus had to rely on adequate charting of doses and timing of levels to ensure accuracy. I would like to thank my investigational team. I look forward to any questions at the end.
Thank you so much, Bethany, for that presentation. And just a reminder to our attendees, go ahead and submit any questions you have for the presenters in the presenter group chat, and we'll take them at the end of this presentation. So next we'll be hearing from Della. Della Zhu is currently completing her PGY2 solid organ transplant residency at Beth Israel Deaconess Medical Center. Following residency, she is excited to take a position at Virtua Our Lady in Lourdes Hospital in New Jersey. Today, she will be presenting on her PGY2 research project, the impact of tacrolimus IPV and TTR on the development of de novo donor-specific antibodies in kidney transplant recipients.
Thank you, Lauren, for the introduction. Please let me know at any time if you can't hear me. As Lauren had mentioned, for my research project this year, I evaluated the impact of tacrolimus IPV and TTR on the development of de novo donor-specific antibodies in the kidney transplant population. The development of de novo donor-specific antibodies is one of the major contributors to antibody-mediated rejection, which accounts for over 60% of graft loss after kidney transplantation. The optimal management of AMR remains uncertain, therefore optimizing the maintenance immunosuppression to prevent development of de novo donor-specific antibodies becomes very important to minimize the risk of AMR in kidney transplant recipients. Here is a graph that compared death sensor graft loss between patients with history of AMR versus no history of AMR. The x-axis represents time in months, and y-axis represent the percent graft survival. We can see that patients without any history of AMR has a graft survival closer to 90% 5 years after transplant, whereas patients with a history of AMR, the graft survival by 5 years is only around 50 to 60%. Tacrolimus is one of the calcineurin inhibitors used to prevent organ rejection in kidney transplant recipients, and in 2007, the Symphony study reported favorable graft outcomes with tacrolimus over cyclosporin, and since then, tacrolimus has become the more common calcineurin inhibitor used in kidney transplant recipients. Tacrolimus has a really narrow therapeutic index where overexposure can lead to higher risk of infections and adverse effects, but underexposure can lead to increased risk of rejections and worse graft outcomes. Due to the narrow therapeutic index, careful therapeutic drug monitoring is warranted to allow for safe and effective use of tacrolimus to prevent rejections. Although tacrolimus trough monitoring has been the standard practice, the trough concentrations can fluctuate over time in some patients, even in the absence of tacrolimus dose adjustment, and these fluctuations we see is related to the tacrolimus intrapatient variability. IPV, which stands for intrapatient variability, is commonly due to reasons such as medication non-adherence, diarrhea, drug interactions, drug-food interactions. Prior studies demonstrated that increase in IPV can lead to poor clinical outcomes such as rejection of renal function, increased rates of rejection, and graft loss. From prior literature, the range of tacrolimus IPV is between 14 to 40%, and IPV is also commonly referred to as coefficient of variation, calculated with standard deviation over the mean tacrolimus trough level. In addition to the IPV, another downfall to tacrolimus trough monitoring is that it fails to capture the tacrolimus exposure beyond the single point level. And this is where TTR comes into play. So TTR is the percentage time in therapeutic range, defined as the percentage time within the therapeutic range over time. It does takes into stability, intensity, and consistency into consideration simultaneously. And this TTR is a validated method for assessing effective warfarin therapy, where the transplant community derived to be used for tacrolimus. And from prior studies, there are limited studies investigated the use of TTR in transplant, demonstrating that low tacrolimus TTR was associated with a significantly increased risk of development of de novo donor-specific antibodies in kidney transplant recipients. And due to the limited prior literature, we decided to further evaluate the role of IPV and TTR in terms of tacrolimus monitoring this year for my research project. The objective of our study was to determine the impact of tacrolimus IPV and TTR on the development of de novo donor-specific antibodies in kidney transplant recipients. The primary outcome of the study was the mean IPV and TTR of patients, comparing the de novo donor-specific group versus the non-DNDSA group, or the control group. Some of the other secondary outcomes we looked at were all-cause mortality, death sensor graft loss, and rejection. This was a single-center retrospective study where patients were divided into two groups, the control or the non-DNDSA group versus the de novo donor-specific antibody group. Patients are first screened for the development of de novo donor-specific antibodies, then a randomly matched control group was selected to compare. Here are the inclusion and exclusion criteria of our study. Patients who are less than 18 years of age maintained on immunosuppression regimen other than tacrolimus, mycophenolate, mofetil, or sodium, plus or minus steroids, positive for pre-transplant DNDSA, failed to undergo DSA screening post-transplant, or if they received a multi-organ transplant were excluded. From January 2014 to December 2018, 297 patients received a kidney transplant at Beth Israel Deaconess Medical Center. A total of 20 patients developed de novo donor-specific antibodies post-transplant. 6 patients were excluded due to change in their maintenance immunosuppression, and 1 patient was excluded due to follow-up time less than 1 year. In a total, 51 patients were included in the study analysis, with 13 patients in the de novo donor-specific antibody group and 38 patients in the control group. When comparing the baseline demographics between control and DNDSA group, patients in the DNDSA group were primarily of higher immunologic risk, such as higher number of HLA mismatch and higher CPRA, African American race, and longer cold ischemic time. Based on our institutional protocol, the majority of our patients received ATG and approximately for induction, and approximately half of our patients underwent steroid withdrawal. For our primary endpoint, mean TTR is measured at time points 3, 6, 12, and 24 months did not reach statistical significance, but there was a trend towards significance at 12 months with a p-value of 0.08, as demonstrated by the bar graph here. When comparing the mean IPVs at the same time frames, 3, 6, 12, and 24 months, again, it was not statistically significant when comparing the two groups. Rates of biopsy-proven rejection were significantly higher in the DNDSA group, 38.5% versus 5.2% with a p-value of 0.008. One patient in the de novo donor-specific antibody group experienced death sensor graft loss due to chronic antibody-mediated rejection. When evaluating the IPV and TTR of patients who developed de novo donor-specific antibodies and rejection, the results were concurrent with our prior literature where IPV greater than 40% and TTR of less than 40% was correlated with high rates of DNDSA development and rejection. In conclusion, although the differences in TTR did not reach statistical significance between the two groups, patients in the DNDSA group had a trend towards statistical significance at 12 months, suggesting that TTR may have a more impact than IPV in predicting de novo donor-specific antibodies development following renal transplantation. The impact of TTR, though, on predicting de novo donor-specific antibody following renal transplantation still requires confirmation in larger studies. And lastly, I do want to thank you all my co-investigators. And thank you so much for the opportunity to present. I look forward to the questions at the end.
Thank you so much, Della, for that presentation. Next, we'll be hearing from Domenica, Ricciuti, and Alyson Prom, who are completing their PGY1 residencies at the University of North Carolina, Chapel Hill. Domenica is an ambulatory care resident, and Alyson is an acute care resident. They have each a vested interest in the solid organ transplant population and are excited to present the research on the impact on a clinical pharmacist can have within an outpatient heart transplant clinic. Domenica attended pharmacy school at the University of Pittsburgh and is excited to continue her training as a PGY2 ambulatory care resident at UNC. Alyson attended pharmacy school at the University of Wisconsin-Madison and is looking forward to completing a PGY2 solid organ transplant residency at UNC this upcoming year.
Thank you so much for that introduction, Lauren. Domenica and I are both here together, so if at any point you can't hear one or the other of us, just let us know. All right, so to start with some background for our presentation here, we have deducted per UNOS and ISHLT that a pharmacology expert has become a major key member of each multidisciplinary team, especially for transplant hospitalizations. Typically, this takes place in the form of a pharmacist, as I'm sure all of us are very familiar with. However, across the country, very few heart transplant clinics employ a full-time dedicated clinical pharmacist for their specific clinic. In addition, some of the data has shown that within the abdominal transplant clinics, pharmacists have been able to improve cardiovascular risk factors, medication adherence, and drug-related problems within their patients. In data relating specifically to heart transplant recipients, they've been shown to have better graft survival by preventing chronic allograft vasculopathy, or CAV, by optimizing their immunosuppression, and by ideally managing their metabolism and things like blood pressure, diabetes, and such. And we feel that pharmacists are primed in the clinic setting, especially, to be able to help manage some of these states for these heart transplant recipients. So the objective of our project this year was to assess the impact of adding a specific dedicated ambulatory clinical pharmacist to the heart transplant team and study clinical outcomes at 1 year post-transplant. So for this study, we completed a retrospective single-center chart review study where we assessed heart transplant recipients at UNC, excluding those with multiple organ transplants or any deaths prior to index hospitalization discharge. On the slide, you can see the dates for both our pre- and post-pharmacist cohorts. Each are about 2 years of length, and the pre-pharmacist cohort had 28 heart transplant recipients. The post-pharmacist cohort had 31, for a total study population of 59 heart transplant recipients. For primary outcomes, we assessed blood pressure less than 140/90, hemoglobin A1C less than 7%, Tacrolimus CV less than 30%, on aspirin therapy, on statin therapy, and on appropriate statin therapy. And this was all assessed at 1 year post-transplant. For our secondary outcomes, we assessed incidence of CAV, incidence of DSAs, treated rejection, all-cause hospitalizations, and all-cause mortality. And these were also assessed at 1 year post-transplant. And then for statistics, we utilized paired t-tests and chi-squared tests. So this is a graph of our baseline demographics between the total cohort as well as each individual cohort, aligned with their statistical p-value on the right-hand column here. I just really want to point out that there were no statistically significant differences within these baseline demographics, and we looked at several different things, especially pertaining to our primary outcome. We made sure to assess pre-transplant diabetes, pre-transplant hemoglobin A1C, LDL, and other things that would affect some of those metabolic outcomes that we were specifically looking at. Of note, in addition, each heart transplant recipient saw, on average, had about 12 visits with the ambulatory pharmacist throughout that first year following their transplant. So on average, once a month. So here you can see this graph depicting our primary outcomes at 1 year post-transplant. On the x-axis, we have the outcomes that we assessed, and on the y-axis,
We have the percentage of heart transplant recipients meeting these outcomes. We have the post-pharmacist cohort in the blue and then the pre-pharmacist in the orange. And as you can see, overall, the pharmacist had a positive impact on most of these outcomes. And we saw statistically significant improvements with at-goal blood pressure, on a statin, and then also on an appropriate intensity statin.
In terms of our secondary outcomes that were measured at 1 year, of all the different things that we looked at, the main outcome that was statistically significant between the two groups was the total number of readmissions, which was significantly lower in the post-pharmacist cohort, like we kind of already alluded to. In terms of CAV, DSAs, and rejection rates, there was no major difference between the two groups.
This table is summarizing the immunosuppression for both the pre and post-pharmacist groups, along with their p-values, and we assess things like median tacrolimus levels, median tacrolimus variability, mTOR inhibitor use, mean prednisone total daily dose, and mean mycophenolate mofetil total daily dose. And of these, the only one that was significantly different was mTOR inhibitor use at 12 months. There was more mTOR inhibitor use in the post-pharmacist group. And this was a thought-provoking finding for us. And part of it, we think, could be that the pharmacist was able to kind of recommend more individualized immunosuppression regimens. But we also have to take into account that during the post-pharmacist cohort time period, that it could be that just in general, the transplant team is just more comfortable during that time point with mTOR inhibitors. And then also a possibility that there was just more data during this time period in regards to mTOR inhibitor use.
So as we've kind of, demonstrated to you based on the data that we found, the pharmacist presence in our ambulatory heart transplant clinic helped improve our patients meeting their goal blood pressures, as well as ensuring that patients were using statins at baseline, but then also ensuring that they were on appropriate doses or intensity of statins. Most often this was utilizing a higher intensity statin than previously. In addition, we also found that pharmacist presence may have an impact on reducing the number of hospitalizations. Obviously, this is an outcome that there are lots of different confounding factors that are playing a role within this. So it was kind of an interesting outcome, one that we weren't necessarily expecting to find, but an intriguing point nonetheless. In addition, as Domenica mentioned too, pharmacist presence may help increase the use of mTOR inhibitors where they are appropriate within their heart transplant recipient populations. Some major limitations of this study was the relatively small sample size, as well as a relatively short follow-up period of 1 year post-transplant. This is especially relevant when discussing outcomes like CAV, which usually tends to show up at time points past that 1 year post-transplant mark. So we may have potentially missed some impact there. In addition, we also mostly looked at clinical outcomes instead of drug-related problems like most of the existing literature identified. So rather than, purely counting the number of drug interactions or interventions made, we really tried to look at some of those big transplant outcome measures that matter for the patient, for the transplant centers, and kind of overall for the transplant success as a whole. The major strength of our study was that no other team member or protocol changes were made during our study period. So basically all of the assisting providers and nurse practitioners and everybody involved, even with the nursing managers and things like that, stayed the same. And the pharmacist that was dedicated and coming into the heart clinic basically was the only team member change within that time period.
We would like to acknowledge our advisor, Christina Dologowski, and then also Krista Walter, who's a PGY2 here at UNC, completing her transplant PGY2, who flipped this project to us, and then Jessica Newman, a student that assisted us, who's now graduated. Thank you.
Great. Thank you so much to the both of you for that excellent presentation. Next, we're going to hear from McKenna Pearson of PharmD. She's a PGY2 pharmacy resident in solid organ transplant at Medical University of South Carolina in Charleston, South Carolina. McKenna completed her pre-pharmacy studies and Doctor of Pharmacy at Regis University in Denver, Colorado. Then she completed a pharmacy practice residency at Presbyterian St. Luke's Medical Center and the Rocky Mountain Hospital for Children in Denver, Colorado. McKenna's interest areas within the field of transplantation include transplant infectious diseases as well as transplant outpatient practice. McKenna's research project this year focuses on the role of specialty pharmacy services in facilitating the approval, initiation, and monitoring of direct-acting antiviral therapies subsequent to the transplantation of a hepatitis C virus-positive organ into a hepatitis C negative donor. McKenna, I am not sure if we can hear you.
Are you able to hear me now?
Yes, perfect. Thank you, McKenna.
All right. Sorry for the technical difficulties. Thank you all so much for your time today. I'm going to be talking to you a little bit about my research project here at MUSC, which specifically looks at the use of hepatitis C medications for the treatment of hepatitis C in patients that receive hepatitis C organs from NAT-positive donors, and a little bit about our specialty pharmacy services program here at MUSC, which I'll abbreviate as SPS throughout the rest of the presentation. So in terms of programmatic challenges to having a hepatitis C transplant program within your center, there are several, but most of them focus on the cost of these medications. So these are high-cost medications, which results in nearly all insurers requiring some barrier for you to jump over prior to patients gaining access to these medications, whether it be a prior authorization, maybe even 2 prior authorizations, and then in some cases even an appeal. So the issue with this is that with these insurers requiring these prior authorizations, which of course is abbreviated PA, on nearly all direct-acting antiviral therapies, this presents a barrier for patients, one, not only getting access to these medications, but a delay in them starting their therapy, given these barriers that people have to jump over to gain access. Now, if any of you have done a prior authorization or appeal before, you know that getting access to these medications, while this process sounds easy, can be pretty challenging and time-consuming. And the more experience you have, the easier this process tends to go. And so having our specialty pharmacy services program here has really shown us the efficiency that can be gained from having people that are specifically trained and gaining people access to these medications. Next slide, please. So our program here at MUSC started back in 2017. At that time, we were just enrolling kidney transplant patients that were interested in receiving a hepatitis C positive organ transplant. And what that process looked like was patients were enrolled after receiving education session from the physician, letting them know about the different outcomes for hepatitis C positive organ transplants, any potential things that could happen following transplant in terms of side effects or potential complications, and then the potential benefit of these organs, which of course is receiving an organ from a healthier donor with fewer comorbidities and potentially waiting shorter on the transplant wait list. So we performed our first transplant in 2019 and since have extrapolated these protocols to all organ types to offer hepatitis C organ transplants to patients with kidney, liver, heart, and lung on the wait list. So our program here at MUSC offers specialty pharmacy services, which of course includes prior authorization and appeal assistance for these patients, overall patient assistance, whether that be copay assistance or any other assistance that they may need in being successful with their therapy, ongoing medication counseling and clinical monitoring with our outside specialty pharmacy services pharmacists being the ones that are ordering the labs for these patients and following up on them and ensuring they're achieving their SBR after completion of their therapy. The benefit and the beautiful thing about this program is that it's available at no additional cost to the patient, so they're getting a lot of bang for their buck in that way. And then they can also facilitate free home delivery and monthly medication refill reminders for these patients because from the studies, we know that patients that take their medication as indicated, meaning not missing any doses, taking it at the same time every day, tend to have near 100% SVR rates for hepatitis C post-transplant. So that's obviously what we're going for, and we're able to mimic that when we have people that are there helping them, counseling them, making them stay on track with their DAA therapy. Next slide, please. So here at MUSC, our hepatitis C protocol is pretty standardized between all patient populations. As I mentioned, we did our first kidney transplant in 2018 and have since extrapolated that to all organ types. And overall, our protocol says that we draw a hepatitis C PCR and genotype 4 to 7 days following transplant. And then in the event that their PCR is too low for us to detect a genotype, then we'll repeat that every 3 to 7 days until we have a genotype that we can move forward with prescribing DAA therapy for. And we treat all patients outpatient unless you're one of these three categories, which includes an increase in your LFTs greater than or equal to 3 times the upper limit of normal without any other cause that can be explained for that, pancreatitis without known cause, or a patient that's anticipated to remain inpatient greater than 1 month following transplant. All of our patients here at MUSC get 12 weeks of DAA therapy. Now, we do direct their therapy based off of the genotype that we identify. Unless, of course, it's our heart transplant patients, then we opt to put them on Mavorite, given the interaction with sofosbuvir-containing regimens and patients that were on amiodarone prior to transplant. But we're going to tailor those to patient based off of genotype and prior DAA exposure. But all patients are going to get a total of 12 weeks of therapy. And then outpatient, we monitor patients for their hepatitis C viral load, CBC, CMP, and we monitor them at a timeline of 4, 12, and 24 weeks from the start of therapy. Next slide, please. So my study this year was a single center retrospective analysis that included patients from January 1st, 2019 through November 1st of 2020, and included all patients with documented labs at 12 weeks following therapy, or essentially weeks that had patients that had accounted for 8 weeks of total therapy that had been administered. So for this time frame and including these patients, we found 64 patients that had received a hepatitis C antibody positive transplant. Of those, 25 of them were NAT negative transplants, and so they did not seroconvert, and then therefore those patients did not require DAA therapy as a result. There were 39 NAT positive organ transplants that occurred at that time. And then of these 39 patients, 25 of them had completed that time marker of 12 weeks of therapy. Of these patients, 32 of them had achieved a sustained virologic response, or essentially were undetectable within 4 weeks of starting therapy. 92% of these patients had achieved SVR or were undetectable within 12 weeks of starting therapy. And 100% of patients achieved SVR24 and therefore achieved clinical cure of hepatitis C following their organ transplant. Now here in this table, I have some of the outcomes in terms of specialty pharmacy services on-site here at MUSC versus specialty pharmacy services outside of MUSC, and different outcomes that we saw. So just a little bit of background behind why we were looking at these specifically. So when going into this project, looking at the literature tells you that when you have specialty pharmacy services that are covering and helping patients to gain access to these medications, it decreases the time to getting insurance approval, and it decreases the time to them starting therapy. However, there isn't a whole lot of data or documented evidence out there that having an on-site specialty pharmacy service, whether that is better having your own versus having one that is referred to an outside specialty pharmacy service. And then the point that we were really trying to look at is if we have our own on-site specialty pharmacy service, does it take it a step farther and actually generate revenue for the institution by having that service available? So when we looked at our population of patients included in this study, we can see that patients that filled at our on-site specialty pharmacy service primarily had a government-funded insurance, with fewer patients having private insurance. And then directly correlated to that, we can see that patients that were required to fill at an outside specialty pharmacy service had private-funded insurance. So we see that pretty commonly with our patients here. If you have government-funded insurance, you tend to be able to fill with our service. However, private insurance tends to be a barrier to that, requiring fill at outside pharmacies, such as Optum Specialty Pharmacy. Additionally, the next data point that we see here is consistent with the data that we have talked about in the past, which is time to insurance approval is significantly different when an on-site specialty pharmacy is used as opposed to an outside specialty pharmacy. with a time point of 19.7 versus 26.5 days to insurance approval, which of course was found to be statistically significant. In addition to that, we can see that time to direct-acting antiviral therapy initiation is also significantly different when an on-site pharmacy is used, with a time to 23.7 days, as compared to an outside specialty pharmacy with a time point to DAA therapy start of 51.3 days, which again is statistically significant. So when putting all of this information together, what we found was that when using our on-site specialty pharmacy service for these patients, we were able to decrease the time to insurance approval by 1/3, and we were able to decrease the time to the start of therapy by 1/2. So significant reductions in both the time to approval and the time to initiation of DAA therapy when patients use our specialty pharmacy service as opposed to an outside specialty pharmacy service. Next slide, please. In addition to these outcomes, here are some other outcomes that we found from this study. So kidney transplant recipients that received a hepatitis C antibody positive organ waited on average 2.78 years. We took this population and compared it to a cohort matched population here at MUSC, matched for gender and age, and these patients waited on average 4.35 years for a kidney transplant. So we can see a significant reduction in time on the wait list for a cohort matched population of patients when they opt to receive a hepatitis C organ as compared to not receiving a hepatitis C organ, and that's found to be statistically significant. And then the thing that we were really hoping to see is this next bullet point here. So if we have this specialty pharmacy service and if we're putting so much work into it, is it generating revenue for our institution? And we were astounded by the results that we found here. So on average, DAA therapy generated $38,000 of net revenue for our institution per 12-week course per patient. So putting all of this work into these patients and really ensuring that they have great compliance also is generating revenue for our institution, which was something wonderful to see. Now, while that's a great thing to see, counter to this, we can also see that this is available at almost no cost to these patients. So on average, the total out-of-pocket cost for patients was $10 per 12 weeks of therapy when they used our on-site specialty pharmacy service, which I think is pretty significant, especially given the lower socioeconomic status of the patient population we serve here in Charleston, South Carolina. And then additionally, patient utilization using MUSC specialty pharmacy was associated with 99.8% adherence. Next slide, please. So just to leave you with some conclusions of this study, overall, we would say that the use of specialty pharmacy services on site is associated with decreased time to direct-acting antiviral therapy approval and time to initiation. Additionally, we would say that specialty pharmacy services provide additional monitoring and patient education that allows us to achieve a near 99.8% adherence rate for these patients. And then lastly, on-site specialty pharmacy services can generate revenue for your institution while helping patients gain access to DAA therapy at little to no cost to them. Lastly, I'll say that the limitations of this study would just be the small sample size, given the short window of time that was collected for these patients and the time that our program has been in existence. However, I say that these results are pretty promising and we'll continue to collect on these moving forward. And then lastly, I just want to thank the preceptors that guided me through this presentation, including Neha Patel and Felicia Bartlett. Thank you so much for your time. I'm happy to take any questions that you have.
Great presentation. Next, we're going to move to Melanie. Melanie Mahoney is a graduate of the University of Minnesota College of Pharmacy and a current PGY1 resident at University Health in San Antonio. She's excited to be staying at University Health next year for a PGY2 and solid organ transplant. And today she'll be presenting on her PGY1 research project, evaluation of a weight-based mycophenolate mofetil dosing protocol for kidney transplant maintenance immunosuppression.
All right, thank you for the introduction. So like you said, I'll be presenting my PGY1 research project on an evaluation of our weight-based mycophenolate mofetil dosing protocol for kidney transplant maintenance immunosuppression. So as we all know, maintenance immunosuppression is used to prevent rejection and loss of graft post-transplant. Mycophenolate mofetil, or MMF, Tacrolimus, and prednisone are the most commonly used agents for maintenance immunosuppression. In 2019, 65% of kidney transplant recipients used this 3-drug regimen post-transplant. and 28% received MMF and tacrolimus. So that means that 93% of all kidney transplant recipients received MMF as part of their maintenance immunosuppression regimen. MMF is typically dosed as 1,000 milligrams by mouth twice daily, which is a dose that's been shown to decrease biopsy-proven acute rejection. However, the gastrointestinal and hematologic toxicities that are associated with MMF often require dose decreases. So the purpose of this project was to evaluate the safety and efficacy of a weight-based mycophenolate mofetil dosing protocol in adult kidney transplant recipients. This retrospective review included adult kidney transplant recipients. The exclusion criteria were basiliximab induction, previous transplant, multi-organ transplant, black race, or delayed or slow graft function. So prior to implementation of the weight-based MMF protocol, all patients received MMF dosed as 1,000 milligrams twice daily. With the weight-based protocol, patients over 80 kilos still receive 1,000 milligrams twice daily. However, the patients that weigh less than 80 kilos receive a reduced dose. So outcomes assessed in this study included incidences of rejection, infection, hospitalizations, leukopenia, neutropenia, G-CSF use, and MMF dose changes within 1 year post-transplant. Leukopenia was defined as a white blood cell count less than 4,000, and neutropenia was defined as an ANC less than 1,500, with severe neutropenia as an ANC less than 500. So here are the baseline characteristics of our patient population. As you can see, our patients were mostly male, middle age, mostly Hispanic, and diabetes was the most common etiology of kidney disease. There were numerically more patients who weighed greater than 80 kilos in the weight-based MMF group, but there were no statistically significant differences in the baseline characteristics between these groups. So shown here are the outcomes at 1 year comparing both groups. There were no significant differences in rejection, infection, or hospitalizations between patients who received a fixed dose MMF and those who received MMF according to the weight-based protocol. This next figure here shows the outcomes specifically in the patients who weighed less than 80 kilos, since these are the ones who received a reduced dose of MMF with our weight-based protocol. So once again, there was no significant differences in incidence of rejection, infection, or hospitalization. We also reviewed the reasons for hospitalization, noting if the admissions were related to infection, GI adverse effects, or neutropenia. There was no difference between the groups for hospitalizations related to infection or neutropenia, but there were significantly fewer hospitalizations associated with non-infectious GI adverse effects with patients in the weight-based MMF group. So shown here is a figure with the incidences of leukopenia, neutropenia, severe neutropenia, and G-CSF use. There were no statistically significant differences in these outcomes. And this figure shows the mean MMF dose at 1 year for all patients, as well as patients who weighed less than 80 kilos and those that weighed 80 kilos or more. The black error bars represent the standard deviations. So as you can see, by 1 year post-transplant, the mean dose for all patients was very similar regardless of the protocol or the weight category. So this study is limited by the fact that it was a retrospective review with a small sample size, especially when we compared those subgroups by patient weight category. And there's also a high rate of dose changes that resulted in similar average MMF doses at 1 year post-transplant. Finally, our weight-based MMF group was compared to a retrospective cohort, so there's the potential for confounding factors there. So in summary, our study found that our weight-based MMF protocol was associated with fewer hospitalizations related to GI adverse effects, but there were similar incidences of rejection, infection, hospitalizations, myelotoxicity, and MMF dose changes between the groups. There is possibility for type 2 error due to small numbers, so further data is needed ideally in a prospective study, to determine if weight-based MMF dosing is advantageous post-kidney transplant. So finally, I'd just like to thank my preceptors and collaborators for their support and contributions to this project, and thank you all for your time today.
Thank you so much. To wrap up the webinar, we'll be hearing last from Dana Pierce. She's a current PGY2 solid organ transplant pharmacy resident at University of Illinois, Chicago. She graduated from UIC College of Pharmacy in 2019 and completed her PGY1 as well as UIC. She has a strong clinical research interest and will be presenting on her center's experience of Belatacept use in obese renal transplant recipients.
Okay, thank you for that introduction. To start off, I have no conflicts of interest to disclose. And to start off with some background, there have been a lot of advancements in the maintenance immunosuppression strategies since the first solid organ transplant in 1954 that have brought us to our current maintenance strategies today. So initially, corticosteroids were the only immunosuppression being utilized in the 1960s, with the addition of azathioprine shortly thereafter, and then subsequently in the 80s, triple therapy emerged with the utilization of cyclosporin, azathioprine, and steroids. And by doing this, the one-year allograft survival rates increased from about 50% to about 75 to 80%. Then, a decade later, Tacrolimus and mycophenolate demonstrated better outcomes than their predecessors, resulting in these new medications as the backbone of therapy, with the one-year graft survival increasing to over 90%. However, due to the unfavorable side effect profile of CNIs, other agents were assessed to try to eliminate or reduce CNI exposure, which is how Belatacept arose. So Belatacept is a derivative of CTLA-4 that binds to CD80 and 86 receptors on the antigen-presenting cells to block T-cell co-stimulation. And it is a novel mechanism of action in that it's the only maintenance agent acting on the antigen-presenting cell as opposed to the T-cell. And Belatacept can be dosed with an initial phase of 10 mg per kg, followed by a maintenance phase of 5 mg per kg, and the New Objects Distribution Program requires patients to be registered with a drug company, but any patient deemed eligible by a provider are eligible to be registered, as opposed to in the past when they needed to have an urgent medical necessity. Its half-life is about 10 days, and the clearance may be increased by body weight. So it's typically dosed based on actual body weight, but that's kind of one of the reasons I wanted to assess this project and see how these larger doses in obese patients may be affecting our patients. And it is a relatively expensive medication, costing of over $1,000 per 250 milligram vial. So since the approval of Belatacept, several different trials have arose in renal transplant recipients that demonstrated a benefit in eGFR after converting to Belatacept. And these results were seen in various combinations of low to high risk donors and recipients. However, none of these studies have assessed the use of Belatacept in obese patients specifically. And since the medication is dosed based on actual body weight, there is a need to assess the efficacy and safety in obese patients receiving these large cumulative Belatacept doses. So the purpose of this study was to compare acute rejection, allograft function, and safety outcomes of obese versus non-obese renal transplant recipients who were converted to Belatacept. It was a retrospective cohort that included adult renal transplant recipients between March of 2018 through May of 2020 at UI Health who were converted to Belatacept. Patients who received multi-organ transplants or were lost to follow-up were excluded, and the primary outcome was the incidence of acute rejection, defined as either biopsy-proven acute rejection or empiric rejection treatment in the absence of a biopsy. We also assessed allograft function, BK viremia, CMV viremia, and best-limited allograft survival and overall survival. And categorical data was compared using chi-square or Fisher's exact test, and continuous variables were compared using independent or paired t-test or Wilcoxon rank sum test. And then univariate and multivariate logistic regression were used to assess acute rejection. Based on our protocol at UI Health, patients were converted to Belatacept for anyone with CNI toxicity, and it was dosed at 10 mg per kg based on actual body weight rounded to the nearest 12.5 milligrams on days 1, 5, week 2, 4, 6, and 8, and 12, and then 5 mg per kg every 4 weeks thereafter. Patients also received a 2-month tacrolimus cross taper with gold tacrolimus levels at 5 to 8 in the first month, then 3 to 5 in the second month, and then discontinued after 2 months post-conversion. And all patients were concomitantly maintained on mycophenolate and prednisone 10 milligrams daily. For the demographics, patients were on average about 53 years old, predominantly male and African American. The average BMI in the obese group was 42.5 kilograms per meter squared compared to 25.4 in the non-obese group. The two groups had statistically similar immunologic risk demonstrated by pre-transplant DSA, high PRA greater than 10%, and positive flow cross-match. The majority of donors were deceased donors, and about a third of the donors were DCD donors, with an average KDPI of about 62%. So in general, these patients had a relatively high risk for rejection. The majority of the patients received thymoglobulin induction. There was about 40% of patients who had delayed graft function post-transplant, and patients were predominantly converted due to CNI-induced nephrotoxicity, and the median time to conversion was 48 days. For the primary outcome, there was significantly more acute rejection in the obese group compared to the non-obese group, which had an incidence of 46.2% compared to 12% respectively, which had a p-value of 0.04. So even despite these patients having much larger absolute doses of Belatacept, they still experienced significantly more rejection of almost half the patients. When broken down into biopsy-proven acute rejection and empiric rejection treatment, there was no statistically significant differences between the two groups, but both tended towards being higher in the obese group, and the average time to rejection post-conversion was about 5 months. When looking at the univariate analysis for acute rejection, obese patients were 6 times more likely to experience acute rejection, while there was no difference when assessing for race, induction agent, high PRA, presence of mycophenolate at time of conversion, or even positive cross-match. The multivariate demonstrated similar findings, with obese patients being about 6 times more likely to experience acute rejection, and the ROC curve demonstrated good performance with an AUC of 78.7%. And as you can see from the Kaplan-Meier curve on the right, there is a clear difference between acute rejection in the two groups, even early on in the first few months post-conversion. While there was more acute rejection in the obese group, the most important aspect is the actual function of the allograft. So we assessed allograft function via eGFR using the NDRD equation. And this graph demonstrates GFR on the y-axis and time post-Belatacept conversion on the x-axis. And there was no significant difference in GFR at any time point, but potentially a clinically significant difference at 12 months, with the obese group having about 10 mils per minute per meter squared greater GFR. So I think that this is an important outcome to take into account, because even though there was more rejection, it was not deleterious to the allograft function, and if anything, may have been even better. There were no significant differences in secondary outcomes, as represented by CMV viremia, no significant difference. BK viremia was similar, death-censored allograft survival, and patient deaths were all similar between the two groups. This study had several limitations. It was a single-center retrospective study limiting its external validity. There was a small sample size of 38 patients, limiting the ability to detect a significant difference. There was also an inability to obtain protocol biopsies due to the difficulties in obtaining biopsies in these obese patients who underwent a robotic renal transplant, which may lead to false positives or false negatives when assessing for acute rejection. In conclusion, Belatacept is indicated in renal transplant recipients who are unable to tolerate inhibitors. This study demonstrated that obese renal transplant recipients who were converted to Belatacept experienced significantly more acute rejection without any significant impact on estimated GFR. So if you are comfortable with assessing and treating the rejection, then using Belatacept in obese patients can still be equally as efficacious, as the renal function still demonstrated the same improvement as the non-obese group. However, future studies are still warranted to further examine the pharmacokinetics of Belatacept in obese transplant recipients. And I think now we'll take any questions.
Hi all. We did not receive any questions from our attendees, so for the interest of time, we'll move on. And I wanted to thank the residents for sharing their hard work this year with us and what they've learned from the research project. Before we adjourn, I want to remind everyone, in order to claim your CE credit for today, you must be an ACCP IMTR member, complete the evaluation at the conclusion, including an active email address. And then the email to claim your CE must be completed within 10 days. And the survey will appear momentarily after the conclusion of the webinar. Have a great afternoon, everyone.